Good afternoon, everyone. Welcome to our webinar. My name is Diane Febby King, and I am a Senior Health Advisor for the National Health Service Corps in the Bureau of Health Workforce at HRSA, and I'm delighted to be here to speak with you today and to enjoy this right now, a new program that we are introducing of the Empowering Clinicians for Resiliency and Transformative Care. The Pipeline Readiness Contract, which is what we've called it for a couple of times prior to today, and now that we have our new title for it, I think it's even more spectacular and really important for you to understand that we're really taking intentional steps to assist our participants in becoming culturally competent through experiences and trainings in root causes of health inequities. We're cultivating the readiness of NHSC Pipeline participants because it's critical to ensure that care is provided to underserved communities from the beginning of their service as an NHSC clinician and or if you're not in your beginning of service. We believe that truly this will serve communities into a deep understanding that's needed regarding the relationship between population health management as well as the impact on health outcomes. Through the awareness of emerging health trends, mentorship, and networking opportunities, the NHSC Pipeline participants can receive support and guidance in advance of their NHSC service to the underserved communities that they're serving in. This in turn can promote resources that assist in recognizing symptoms of burnout, the supporting of the clinician resiliency efforts, and of course, resiliency is the utilization of interrelated components, tools of educational practices, and what we think is such important self-assessment, organizational resources that can bolster and support you in your service. Our resiliency resources also are productive and emotional well-being so that you can have that strength in your own self and hopefully with the collective at your site or as you're going into site, you will have that with your colleagues as well. The purpose of this new initiative is really to create educational products and materials that provide virtual educational technical support. We have a massive amount of NHSC Pipeline participants who are in their first year, and of course, upwards of participants who stay in the community far after they have served their NHSC service. This support that we're providing you today and over time this year will provide educational resources and materials that will include newsletters, webinars, teleconferences, coaching, and mentoring. We think these are focused closely on core competencies that our clinicians really need and more clinicians could use. And those core principles are sometimes engagement of the community, health professional networks, interdisciplinary and community-based practice models, and provider resiliency programs that prevent burnout and support you as a clinician for your well-being. So the resources you'll find within this program will be various formats and aims to engage you. And in brief, it's a concept that custom calculations that bring raw data to life can really be a topic that you can delve into and that you can use that data to support yourself. And this is all the culmination of that with this series. Our community engagement, which we explore in this series, it encompasses advocacy, community-based partnerships, health illiteracy and numeracy, and of course, cultural linguistic competency. Our interdisciplinary and community-based practice models will focus solely on across disciplines, highlighting the importance of the integration of multidisciplinary teams, which we all work in wherever we sit and do in our community. And we think that this needs to be an alignment for you as service providers, such as understanding of payment models, influence on the delivery of care, cultural linguistic and competencies, resilience again, and provider burnout. And we aim to promote more of that for our clinicians' well-being as they move through the process of the NHSC and their site and their community. We also like the concept of the communication that we can have at the sites, their level of discussion with their employer and with each other, and so that they can improve themselves even in community engagement from advocacy on. In closing, from my perspective, it's really our hope that our resource that we've provided to you today and in the coming months is an opportunity for mentorship and support to future NHSC clinicians across the board. We really want to ensure that our providers will be supported in their service as they go through that service, and that the service will ultimately increase your likelihood to stay and remain in underserved communities well after the completion of potentially what you had decided to do in the beginning. Thus, we hope that will eliminate health workforce shortages in the high-need communities across our United States and our territories. So with that said, I welcome you to Clinician Burnout, Predictors, Implications, and Coping Strategies. We hope that you have a successful afternoon with our presenter and the groups that you'll be docking in later on. Thank you so much. I'll turn it back over to you.
Thank you, Diane. That was a really great introduction about our initiative. We're so happy that you're here with us and everyone else who is here in attendance. My name is Molly Mindbress. I am the Associate Director of NHSC Educational Programs at the Association of Clinicians for the Underserved, and I'm going to be your moderator today. We're really excited to have Dr. Bridget Gorley here with us today to discuss the predictors and implications of burnout. As Diane mentioned, we have lots of great topics to share as part of this NHSC Empowering Clinicians for Resiliency and Transformative Care initiative, but we thought it'd be really important to start with burnout. According to the National Academy of Medicine, in their National Plan for Health Workforce Wellbeing, they state that 54% of nurses and physicians and 60% of medical students and residents experience burnout. Rates were really high before COVID-19, and they've only increased in the last 3 years. But fortunately, the conversation around burnout is changing. So we're moving away from mostly focusing on self-care strategies to really looking at recommendations to change the structures and practices where clinicians are working and going to school that are causing that burnout. So we no longer see it as a failure of the individual clinician if they're experiencing burnout, but more a product of the chronic unresolved issues in the workplace. We will make sure to emphasize this point throughout all of our presentations, but really the focus of this first webinar series is on clinicians. We want to show you what burnout can look like in yourself and your colleagues, what might be causing your burnout, and how you can take action to manage your symptoms of burnout and advocate for changes in your organization to reduce burnout. We're also really glad to see that there's quite a few site staff here today. And just so you know, the next series in the initiative is really geared towards leadership staff, administrative staff, HR folks, to look at the practices and policies that healthcare organizations can implement to create supportive and efficient work environments and to prevent high levels of burnout. We'll also cover how leadership can monitor those burnout levels and respond in a timely fashion to change those levels, especially during public health crises like the COVID-19 pandemic. We hope that you all benefit from the presentations we've designed and leave feeling more confident in your ability to manage your burnout and influence your leadership to take the steps necessary to nurture clinician well-being. Before I introduce Dr. Gorley and let her get started, I'm just going to go over a few housekeeping options. We want to help you all get familiar with the webinar room and let you know what to expect. So this webinar is being recorded, and we'll send a link to the recording in 2 days after the webinar. The PowerPoint slides and related documents are available on the webinar information page, which is linked in your email invitation. These documents should also be available in the NHSC portal if you are an NHSC participant or a site point of contact. This is a 2-hour webinar, and in the first hour, Dr. Gorley is going to talk to us about the predictors and implications of clinician burnout. We will have time for Q&A at the end of the presentation, so please type any questions that you have for Dr. Gorley in the chat box on the right side of the screen. If you don't see the chat box yet, you may have to manually open it, so click on the chat icon in the bottom right corner of the webinar window. If you raise your hand during the presentation, we won't be calling on you until the end of Q&A if there's time. So if you do have a technical assistance question, please contact Josh. He's our tech support today, and his information is posted in the chat. For the second hour of the webinar, we will have time for networking and peer mentorship by clinical discipline and for approved site staff. So Please stay for that second hour to connect and share ideas with your fellow NHSC participants and approved site staff. Lastly, to see closed captioning, click on the CC icon in the bottom left corner of the webinar window. I think you're all going to really enjoy hearing from Dr. Bridget Gorley today. She has 22 years of experience in underserved care, interprofessional practice, and nursing education. She's also a former National Health Service Corps scholar. She has extensive experience working with similar populations as many of you, and currently practices at a community health center and within a behavioral health home, providing primary care to adults with severe and persistent mental illness. In addition to clinical practice, Dr. Gorley is also an assistant professor and program director at the University of Maryland School of Nursing for the Family Nurse Practitioner Doctor of Nursing Practice program. As faculty, Dr. Gorley develops and delivers curriculum to prepare students to care for underserved and vulnerable populations. The focus of that work is on interprofessional team communication, trauma-informed care, and innovative care delivery models to meet the needs of patients, communities, and healthcare providers. Dr. Gorley, I'll hand the mic to you now, and it's okay if you go a little longer. We have a couple hours today, so I just want to make sure you have time to do the whole presentation. Thank you.
Well, thank you so much for that introduction, Molly. I really appreciate it. And thank you for those of you on the webinar for attending and taking the time for yourself to learn a little bit more about what many clinicians are facing right now. I know there's some administrators on the line as well. And what we really need is a full court press, right, of everybody to sort of learn more about burnout and how to identify it in ourselves and our colleagues so that we can really continue to do this very important and very hard work that we're doing out in the communities with our underserved folks across the country. So I applaud you for taking time away, probably from clinical duties, and I hope that it will not extend your day too long beyond the usual clinic day. So like all presentations, we're going to start out with some learning objectives, pretty straightforward. We're just going to look at what actually burnout is, look at some of the factors that relate to it, and then how it impacts you as a clinician, but also it can impact your colleagues. It also impacts the patients, looking at the signs of burnout, and then also looking at some strategies. As was discussed earlier, this is the first in, I believe it's 5 series. So this is just going to be sort of a big picture overview, a little bit of definitions, and we're going to talk about some of the strategies. But the following sessions will have a deeper dive into the different tools we use to assess, different coping strategies that you can really apply for yourselves and maybe help some of your colleagues with. And but this will just sort of set the stage. So burnout, what are we talking about here? I think we all have an idea of what we think it is, but according to the World Health Organization, it's a syndrome conceptualized as resulting from just chronic workplace stress that's not been successfully managed. And as we discussed before, a lot of times we used to look at this as a sort of me problem, like, oh, I'm burnt out, without really looking at the bigger picture problem of what else is going on outside of the individual that might be contributing to this burnout. What we know is it's not technically a medical condition, but it can lead to a lot of physical and behavioral health issues within the provider themselves. And there's also ripple effects from that. The 3 dimensions of burnout act separately, but they also interact with each other. And sometimes the impact can be really severe for clinicians. And they can be caused by different factors, and the coping strategies that we need to use really need to look at the root cause of the burnout in order to be effective, right? So it's not going to be a one size fits all. And what we're hoping is through these webinars that you'll learn some really tailored options to help you. Ultimately, we're hoping you can prevent burnout, grow resilience. But if you are feeling burnout, maybe there are some resources that can help you right your ship. So the 3 dimensions of burnout, really, who is not feeling a sense of exhaustion and energy depletion? the work that you do in the communities where you are with underserved folks, and usually in medically underserved areas, you're going to feel some energy depletion. But there's a difference between feeling fatigue and then there's exhaustion, right? So that's the first step, energy depletion and exhaustion. And this was happening before COVID in the communities and the health centers where you are. 20 years ago, this was the case when I first was a health service corps clinician. COVID has augmented that. And so we'll probably have to really just be aware that these are unprecedented times. Of course, we've heard that before, but really now we're looking at, okay, what can we do at a systemic level to sort of mitigate this? When we have increased mental distance from work, that might be, you might be experiencing this as a sense of dread, right? Like, ugh, I have to go to work. Or you might not be too bad going to work, but maybe you're not really thrilled about seeing your patients. And that's really what a lot of you are there to do, right? So that's not going to work long term. And then a sense of decreased professional efficacy. So you might be thinking, oh, I am just really not doing a good job. And some of that could be perceived. You think that you're not doing a good job, which gets in your head. But the other thing is that you actually could have the decreased professional efficacy. So it can be real and it can be perceived, but either way, it sort of weighs heavily on your mind and gets in the way and can contribute to burnout. So what we see here is just a really simple graphic of how when we increase our resiliency factors, we reduce the burnout. And so we know that organizations play a huge role in this as they create metrics for us as providers, patient flow, et cetera. We know that the organization itself can also work to reduce burnout through, different sort of processes that make work possible, that make work flow in a way that is meaningful and sustainable. I was just at a nursing practice conference about 2 weeks ago, and there was a big focus on organizational effectiveness and how it creates sort of a safety net for providers and staff within the organization. And I like that the work on burnout and resiliency is looking more bigger picture, because while we can do a lot of personal work on, creating, great exercise patterns and sleep and good nutrition and all those other things, if we keep returning to an environment where the demands just far outstrip the resources, it's very difficult for us to sustain a sense of resiliency. The prevalence of clinician burnout is pretty high. And again, these are pre-COVID studies, right, that have indicated this. So, somewhere between 1/3 and close to 1/2 of nurses, and somewhere greater than 1/3 to more than 1/2 of physicians experience burnout. And I believe, I don't know if this is specific to health service corps folks and folks working in medically underserved areas, but that's concerning, right? Because we would think our populations and our clinical environments, the rate of burnout may be a bit more. The prevalence rates are going to vary depending on the burnout assessment tool used. And we're going to talk about the different burnout assessment tools in a minute, but there are tools that have, many sections, and sometimes in the studies, they've only used one section. That can be because some of the tools are a little bit longer. But so, buyer beware when you're looking at the different data, because it may not capture the full picture of what's really going on out there, just because different tools, they screen a little bit differently. But it's important for you to know that there's a lot of burnout, and we can't really afford to have it, right? We need all the folks that we can to be out there providing great care, and we need, and there's a lot of work to do. So we need to be able to sustain ourselves and our colleagues to get the work done. There's some really interesting information about demographic factors related to burnout. There are some indications that gender, age, race, and ethnicity have a factor in burnout, but it's a little inconclusive about how it affects it, right? So there's some theories, right? Women consistently report higher burnout in men, but we're not clear on that. Sometimes there's been some theories that the difference might be due to women having more child rearing responsibilities, maybe some more work-life challenges. But other researchers have said maybe some of these challenges are related to more bias in the workplace, and that our female clinicians are spending more time with patients, or they have less control over schedules compared to their male counterparts. Younger clinicians are earlier in their careers, and they might be more at risk just because they might perceive a lack of opportunity to have a say in their schedule and their balance of how many patients can I see? How does my schedule look? Do I have all chronic follow-up patients who are a mess, right? Some of our patients really have a lot more needs than we can fix in a 15-minute visit. Or is there a way that I can block my schedule in certain ways to help me finish my notes, see patients more efficiently? Race and ethnicity, the data is very inconclusive in this, and some of this has to do with the actual assessment tools, right? We're not sure that they really are as accurate as we would like them to be when we're talking about our minoritized populations. And that's really something that we need to do more work on, right? Is to develop the tools to more accurately reflect all of the folks who are involved in giving care and their experiences with it, so that we can more accurately identify the solutions that we need to continue doing this work. So there's lots of personal factors related to burnout. Having children may decrease the experience of burnout. However, I would argue that it probably depends on your family life situation and the complexity of your children. Big life events, loss of a loved one, childbirth, can increase the risk for burnout. I would also say our clinicians who may be juggling both sides of life, young children at home, as well as caregiver responsibilities for perhaps some older adults in their life. This, I think, especially has been the case during COVID, where families were sort of potting up. And these responsibilities may have increased, especially amongst our clinicians, because we have been sort of the go-to resource for all things COVID, directly within the communities and the patients that we serve, but also we've been sort of the go-to interpreter and disseminator of knowledge for our families and our friends, even outside of our clinical work. So how do we measure burnout? There's lots of assessment tools available. Some are costly and some are available for no cost, but this is a list of many of them. So the Maslow Burnout Inventory is the one that's really the most utilized in many of the studies. It has three components, and we'll talk about that in a little bit. The burnout assessment tool is another tool that is newer, and it really attempts to rectify some of the misgivings of the Maslow, and it is also available for free. So these are tools that might provide useful information if you're really not sure what the state of the state is for your clinical providers. If you're an administrator, you might want to consider opening up one of these tools, or it might be an opportunity for you to do some self-study just to sort of get a sense, am I feeling some of the effects of burnout? So the Maslow burnout inventory measures 3 dimensions, right? And these are the 3 dimensions that were sort of talked about earlier: the emotional exhaustion, the depersonalization, and the sense of personal accomplishment. And these are really important to look at. These factors are very important because they sort of are really good indicators of how burnout an individual is, but then also it looks at, okay, what sort of resources do we need to gather up to sort of help the individual through this? All right. And we're definitely going to talk that the deeper dive on the inventories is, I believe, session 2. And I think I just saw Molly put that up in the chat box. So, physical conditions related to burnout. I suspect many of these conditions are probably related to the toxic stress that burnout brings us, right? And if we saw some of these, for my clinicians out there, if we saw these factors in our patients, we would talk with them about mitigating their stress, healthy lifestyle, all these great things that we love to talk to our patients about. However, we are not really great with addressing them in ourselves sometimes, right? Or maybe we do, but we're probably a little harder on ourselves as clinicians than we are on our patients. But these things have a this toxic stress has a cascading effect, okay? And so while it might not cause high cholesterol, cause type 2 diabetes, the toxic stress and what you eat, because you're stressed and you're, crunched for time and you're, trying to juggle a million different priorities, you might be not able to prepare as your healthy food. Even if you don't live in a food desert, you might be sort of stuck saying, I'm gonna, hit the drive-through instead of prepare a meal, just because you're completely exhausted. And over time, these things build up, right? And so we find sometimes that the somatization of some of the stress can really also have the secondary effects on the physical conditions. But the psychological conditions are, just as prevalent, and maybe we ignore them, maybe we rationalize them, but we might be surprised to see that this is actually happening in clinicians and our peers when we normally would expect this to be happening more with our patients. And how would we treat patients if they came to us with some of these questions and concerns? We would try to get to the root cause. And this is what we're trying to do in this webinar. We're trying to get to the root cause, but it's reflected more as a mirror for us, right? We need to look inside and see if we're having some of these issues, because this will help us get to moving towards the solutions. I think part of the trick, whether you're a clinician or an administrator within the clinics, is to create the psychologically safe space for your providers and staff to, number one, feel comfortable to recognize that they're struggling, and also to feel comfortable to bring up these concerns with, whether it's within, your provider panel group or with clinic administrators, because not talking about it, it just, it keeps it hidden, and then it sort of eats you up from the inside out, is the best way that I can explain it. And I've seen this happen, we're seeing it happen all across the country, actually, with nurses. And we're seeing it also within the community, folks not wanting to come to work because they're so depressed and burnt out that they can't even think to come to work another day. So the impact of burnout doesn't just, stop with the clinicians or the front office staff. It has an impact on the patients, right? So we know that we're not great with communicating with folks when we're feeling stressed and we're feeling disengaged, right? But guess what? The patients feel it too. They're like, you don't really care about me. And what do we think happens when our patients think that we are not caring about them? Do they show up for appointments? No, because they don't want to come to see you if they know you're struggling. It doesn't create an environment of care that's very fulfilling for anyone. Bigger concerns, though, are, of course, medical errors, right? You're sort of operating on autopilot. You're maybe not fully engaged in your work. That can lead to medical errors, prescription errors, and then, patient safety incidents, right? So those are all things that we want to prevent, right? We don't want to have that to be the case. We're trying to prevent all those bad outcomes because none of us started this work to have that be part of our plan, right? We have all run into this service profession to help others. And that's the goal. That's where we want to get back to. So there's obviously occupational issues related to the burnout, absenteeism, so the calling out, right? Now, when you're in a environment that's probably operating on very tight margins as far as staffing, and staffing of all levels, whether that's providers, medical support staff, front office staff, there is no wiggle room. We are in underserved areas, and we have been in underserved areas. These areas have been underserved for a long time. So there's just not the wiggle room to have folks not be well and not come to work. And that creates, the trickle down of that is that it sort of helps to contribute to the burnout of other clinicians, right? So job satisfaction, folks might be in a job, but they're going to leave soon, or they're actively looking for work while they're at work. We worry about accidents, disability, and then even showing up to work when you're really not able to fully engage. That creates a safety issue, especially in healthcare. And ultimately, we worry that folks are going to reduce their hours permanently or just leave the field. And, in underserved care, you're in a niche environment, right? There's not everybody can do the underserved care that you're doing. And we need to nurture our providers and clinicians and staff that are within this field, because not everybody could do it. So we have to take care of the folks that are here to be sure that they can be present and continue this work, because it's really important work. The predictors of burnout, well, this we probably is very intuitive, right? When the demands of the job outstrip your ability to do the job, do the actual work. And a lot of these have really novel solutions, right? And this is our opportunity as people who are working in this field to be innovative, right? Too many patients scheduled per day. I mean, let's face it, our patient populations have many, many problems to solve, more than probably could be solved in a 15-minute visit. That has been my experience. And sometimes I know clinically that I had to be very pragmatic with the patients and say, we need to focus on the top 2 things that we can address today. Because if I tried to solve 15 problems for one patient, that meant I was behind, really behind. And the patients behind that patient were often sitting in the waiting room. They were upset, they were disgruntled, and it just creates this toxic stew that you can't work your way out of, right? So when we look at what do our patients need, I think we need to look also at realistic boundaries for productivity, right? Because you can be very productive, but you can't solve every problem all at once. When you have patients with overwhelming needs, the temptation is to try and fix them all. And when you can't complete all those items on the to-do list, where does that work go? It comes home with you. And so then your work life just keeps extending into your home life, which can really, it can be difficult to reel in. And then it can be difficult to get the things that you need to get done at home done. So then you're already behind before you started. And this is one of the things that clinicians often complain about, is I can't get my work done during work hours. And then it bleeds into my life outside of work. And then my family's upset with me, or, you know, I can't do other things to sort of decompress. So the predictors of burnout, pretty easy, right? If you have no say in your schedule and you can't have any input into the organizational decision-making about things that directly affect you, i.e. the number of patients you're supposed to see and how fast you're supposed to see them, that can be a bit suffocating. Efficiency and resources, you know, a lot of times we have these processes in place because we're doing workarounds. Some of that can be budgetary, right? Oh, we don't have a great EMR, so I have to do 5 other tasks to make this EMR work the way other EMRs work, but it's kind of held together with duct tape, and that's suboptimal, right? The other things are having folks do jobs that are not really at their skill set or well beyond their skill set. For example, you know, sometimes because someone's a medical director, they get tasked with like every other administrative task, but it's really, they could be much more useful doing other things rather than working on that. The social support and community at work, if there's not a lot of leadership support and coworker collegiality, that can obviously predict burnout because it's not an enjoyable place to show up. Many of us know that there's a lot of meaning in our work, but sometimes the amount of vicarious trauma and the different challenges with team cohesion and some moral distress, maybe because of policies, make it really hard for us to sustain coming to work. For example, you know, you can come to work and be understaffed for maybe 1 day or 1 week because we know, oh, somebody's sick and it'll get better. But when it just becomes the standard operating procedure to be chronically understaffed, that becomes a bridge too far. This we know, COVID-19 and burnout, as we can see, it increased a little bit, right? But it's a different mechanism. A lot of it had to do with personal safety and feeling like, what am I risking my life by actually going in to see patients? And then also balancing the regular difficulty of work and challenges of work with all these other new challenges and new rules, right? Lots of PPE, spaces between patients, doing telemedicine, all this new stuff that we were supposed to be doing to keep the care going really has come at a cost. So there's additional predictors of burnout, you know, because after we leave work, there's all these other things going on, right? I know some providers actually lost their job and it was like, well, wait, we're in the middle of a healthcare crisis. Can't we use everybody that's a nurse or a nurse practitioner or PA? But because of some of the availability of PPE, scheduling, and reimbursement, some providers wound up leaving or were redeployed to other areas, which was in some cases very scary. If you went from primary care to being on an inpatient ICU, that was very scary. It did not help the burnout situation. So some of the signs of clinician burnout that we see here may be common to you, right? And you may have seen these signs and symptoms in your patients or your colleagues, but I'm encouraging you to see if you see them within yourself. Because this is the tip of the iceberg, right? We want to identify these feelings so that we can look towards identifying solutions. We discussed this a little bit before, but sometimes when we're feeling very burnt out, we tend to sort of hunker down, head down, do your work. If I just focus on my work and I just get through this day, it'll be better, right? And so sometimes that leads you to be a little isolated and not so approachable by your colleagues and other supports at your clinical environment. So it makes you a little out of reach. sleep disturbances, many of us have sleep disturbances, right? Especially if you're working in a hospital and you have an alternative schedule or rotating calls and all that. That's sort of the cost of healthcare. But changes in your insomnia or changes in how much or how little you sleep is really important to recognize. And then we, of course, look at the physical ailments, chronic headaches, neck aches, GI distress, a lot of changes in your eating habits. Those are all signs that we're sort of maybe feeling a little more stressed than we're aware of. So how we cope with our burnout really depends on what's causing it, right? So we want to first, recognize that it's there, but then look at, root cause. Why, right? Why is this happening? Why do we do things this way? And look at the workplace modifications that can occur to sort of mitigate some of this stress. Because we don't want to always be thinking, well, that's a Bridget problem. Bridget can't complete her notes because, she's gabbing with the patients. And I will tell you that is actually true. I have a hard time completing my notes because I am gabbing with my patients, because that brings me an incredible joy to work with the patients. But it does not bring me incredible joy to be at the clinic until 7 o'clock at night writing notes, because that's interfering with my home time, right? And if any of you have experienced that, you know exactly what I mean. So let's talk about some of the different ways that we can sort of chunk our coping strategies to look at problem-focused coping strategies. And I look at these as more of the external factors. Like, so what is it outside of me that is causing some of this burnout and stress? And I look at the environment, right? What is going on within the workplace? It could be patient flow. It could be we don't have enough medical assistants. It could be, a variety of different factors. And some of those were addressed in some questions prior to the webinar, but it seems like there are questions that there are strategies to address the external environment of care that can actually really increase productivity, efficiency, and patient flow. So there's the external factors, and then there's the emotion-focused coping strategies to reduce the emotional harm from this chronic stress. So some of the problem-focused strategies would lead you to talk to leadership. Now, I feel very lucky. I have always had really willing administrative leadership at all the health centers that I've worked at. I know that is not the case everywhere, and I know that is actually not the case for many providers. But finding one or two willing leaders who are willing to listen to your concerns about whether it's a staffing or scheduling or allowing you to have more time with patients so that you don't have that crunch, creating stronger boundaries between work and personal life. For example, we all have laptops, or many of us have laptops, and they're really easy to put in your backpack or your purse or your briefcase and bring them home and be like, oh, I'll work on that later. But committing to finishing that, closing that laptop, finishing those notes during your clinical day, and then leaving that sort of safe space. I'm leaving my laptop at home. Unless you're on call and you need it, leave it at the clinic, because that creates a physical boundary of, you know what, I'm not going to log in. Okay. Using your vacation time. How many folks have vacation time that they haven't been able to use? Some of that is our own feeling of guilt that, oh, the staff, they're already so short staffed. How could I take some vacation time? But I caution you, and remember, you can't drink from an empty cup. And I'm guilty of this as well. So, but it's important. Maybe you can't take a whole vacation day, but take a half a day. Maybe you could sprinkle some of your vacation time and do a shorter day on a few days during the month. And that might, and plan something fun that's going to regenerate you so that you can return to work the next day and have a little bit more to give. Some of the emotional centered strategies is really, I can't encourage you enough to talk with your peers at work because they are folks who are going to understand a little bit more about the stress that you're feeling. Underserved care is a niche. It takes a certain type of person to go into underserved care. And so nobody knows what you're going through more than your fellow NHSC scholars, your loan repayers, your alums, all the folks that are out there, the ambassadors for your support. I found it very frustrating when I was a health service corps scholar to try and talk with some of my other colleagues who were in private practices in very well resourced communities, and they just didn't get it. So you talk with those friends about other things, but if you need to sort of problem solve, I would encourage you to reach out to folks who know what you're living through as far as the clinical environment, but then also seek help from mental health professionals, counselors. Faith communities often have counseling available. And I have to do a little plug, and I don't, it's for Headspace. That is something that during the pandemic, University of Maryland hospital system and the School of Nursing really provided access to that app for their nurses and students because they found it to be really helpful. Physical activity, there's been a lot of talk about getting out and greening, being out in the environment, taking a walk, just some fresh air can often just sort of reboot you. And best if you do that with a friend, if you can find one, maybe vent a little bit about work. But caring for yourself is only part of the solution, okay? And so these case studies that we're going to go through next, we'll talk a little bit more about some of the systemic level changes that might be a possibility for where you're working, as well as some of the internal opportunities that you can have for recharging and growing your resiliency and reducing the burnout. Let me just take one break. Molly, I don't know if there were questions in between or if we should just move right through to the case studies.
Yeah, you can jump straight into the case studies and then we'll do Q&A. Thanks.
Okay, so this is case study number 1. This is Felix Nunez, physician, MPH, National Health Service Corps alumnus. So Dr. Nunez began to feel burnout after 2 years of leaving medical training. He's now the medical director of an urban community health center. The patient population is indigent, immigrant, uninsured. This patient population may be familiar to many of you. So his role includes 50% supervising, 50% direct patient care. Some of his job responsibilities include managing HR issues and the clinician schedules, working with the executive team, supervising the front office, pharmacy, and medical assistants. His burnout symptoms include frustration, fatigue, and depression. Is any of this, in your head, is any of this surprising based on those responsibilities? So what are some of the causes for burnout for Mr. Nunez? First, no control over the schedule. And is it really realistic to be 50% patient care and 50% administrator? And is it really necessary to be an administrator of those particular roles that he was assigned? I would argue perhaps not. Inadequate time with patients. So 50% of time of your week with patients, my questions would be, what happened to his patient panel? Was that reduced in light of his reduced availability? Or did we just think that the same amount of people were going to fit into half the amount of time? Vicarious trauma, we know working with our populations that our populations have had a disproportionate amount of trauma in their lives. And when they are telling their stories, it does create vicarious trauma for us as providers, and it can be triggering. And that you don't leave at the clinic door, right? Because there's high social needs, there's a lot of impact on treating the medical issues. So while we would love to offer the patient X, Y, and Z, we have to prioritize based on what the patient can afford and what resources are available. That does create a little bit of moral distress because you're thinking, how can I make these ends meet for the patient? And then, of course, there's a limited access to specialty and support services because the specialty and support services are often hard pressed to offer services for free. And if you are fortunate enough to have providers and specialists in your area that will offer services for free, then sometimes there is a limit on how many of those services they will offer for free. So oftentimes the need outstrips the resources. So how did he address or manage his burnout? First and foremost, and I mean, I believe he's in a fortunate position as a medical director. He advocated to the leadership team, was able to increase vacation time, increased paid CME time. So to, hone different skills to help with leadership and change within the organizational environment. And also is able to decrease the patient panels, which is important because you cannot manage the same number of patients with 50% of the time, right? And I feel like we do this not just in health service corps and health professional underserved areas. We do this in a lot of clinics and medical offices throughout the United States. Foster continued learning. So in order to mentor and support other providers in the practice, there were physician meetings and grand rounds, which is really important because that builds capacity of other providers to step up, right? The more the other providers learn and grow, the more they are able to chip in. It's this great feedback loop, right? The stronger your providers are, the more they understand, the better they can help the patients, and without feeling so stressed and overwhelmed. So there's provider meetings you can have grand round style meetings. Sometimes providers will peel off of other clinical meetings and they'll focus on, clinical review of some patients. There's a lot of great ideas. So support from colleagues, it does take a full court press to get this work done. And then it did a good job by creating some work-life balance. Did not bring work home. That's very, very hard, especially in that role, but creating some hard boundaries and hard stops really helps. Looking at some other hobbies, because if you have something else to do, you might be more inclined to get your work done at work. And then prioritizing time with family. Taking vacation time is key. Were there any questions about that? I can't. All right.
None in the chat at the moment. If you want to go on to the learning
one.
it. Yep. Mm-hmm.
So the next person is Jasmine. She's a nurse practitioner at a primary care clinic. Her clinic is chronically understaffed, and she spends many nights at home completing documentation and reading labs. This is super common, right? Jasmine has noticed that she is experiencing signs of burnout. She has emotional exhaustion from constantly trying to convince coworkers to assist her when support staff are out, inefficient charting when waiting days after to complete, irritability with her children at home, and anxiety about her workload, and then difficulty falling asleep. So how many of these things are common in your life? Just reflect on that. And then let's look at some of the different solutions that Jasmine was able to employ. So what could she do to improve her situation at work and mitigate the experience of burnout? Just think about that. And what approaches could she take to manage her symptoms of burnout? So some of it is about preventing, right? What can we do to right the ship? And then some of it is just sort of repair, right? So what did she do to improve her situation at work? Started completing chart notes during visits. I hear this from many new grads, and I hear this from new providers orienting, I don't think it matters what EMR you are on. My best suggestion is to develop templates that you can sort of cut and paste and edit. And if you are not a techie person, and I will tell you, I am not a techie person, find a friend, because it can transform your life once you are not buried in your notes. And then planning for staffing shortages. So the staff shortage is chronic right now. It's sort of everywhere. But there are some strategies that are available that can help if someone calls out or if someone's going to be unavailable for an extended period of time. So in this case, she made the first patient of the day a telephone visit or a telemed visit, because that mitigated having a nurse not be there, right? It also frees up some of your front desk staff for checking the patient in and verifying their insurance and all that stuff. So it creates a little bit of a buffer. Use of telemedicine visits, I can't emphasize enough, for those quick follow-up visits, touch point visits. Really take advantage of that, because you provide your providers, but the whole office gets a little bit of breathing space, right? She added midday break for administrative duties. So aside from lunch, because when you're having lunch, you should be eating lunch, not doing your labs and making 500 phone calls and all that. Even if it's just a half hour of focused time, you can click through those labs and those prescription refills. It really can take it off of the end of the day. And then scheduling short visits. So maybe, the 15-minute, not the new patient. This would be the UTI follow-up, or the, otitis media recheck, or, a medication check. Not a brand new patient right before lunch, and definitely not a brand new patient right at the end of the day, or a post-hospital discharge follow-up right at the end of the day, where you're going to encounter some hiccups. She was able to access her mentor for support and advice, scheduled more vacation days, and began leaving work on time when possible. And that's very tricky to do, right? Because there's lots of needs, but it's important, because if you are the person who keeps staying, sometimes that also creates a pattern that is really hard to break. And then the expectation can be, well, I just think people are going to stay, rather than fix these structural issues that are built in that are having you stay, right? So this is a final vignette. This is Tara. She's a physician resident at a safety net hospital. So she serves many patients who are unhoused or unstably housed. So the social issues are enormous. Tara is unable to provide the full range of health and social services the patients need to prevent them from returning to her clinic. She is also frustrated that she doesn't have many mentors who look like her, and because she is a Black woman, she is tasked with mentoring all of the Black physician residents. This is very common in academia as well as in clinical practice. Tara has noticed that she is experiencing signs of burnout. She has compassion fatigue, depression, and anxiety. She has difficulty falling asleep or waking up in the middle of the night due to stressful dreams. Now, what did I forget, right? Not finding joy in things that used to bring her joy, irritability with her partner, neck and shoulder pain, and headaches. However, Tara does not feel safe admitting her burnout symptoms, because as a Black woman in a historically white dominated field, there's not that psychologically safe space. And she does not want to show weakness. What could Tara do to improve her situation at work to mitigate the experience of burnout? And what approaches could Tara take to manage her symptoms of burnout? But what can the clinic do to help Tara? just reflect on that. So let's look at what she did. And some of these are easier said than done, but create better boundaries in the workplace, protected time. For example, those chunks of time during the day when you are supposed to be eating lunch, for example, that needs to be the time that you eat lunch, not the time that you eat lunch and manage 500 other tasks that are sort of lumped onto your to-do list. Limiting commitments. It's very hard to say no when you are in a position where it is expected of you to be the leader, especially for our minoritized communities. And we find this more so, I have spoken with my colleagues about this, where they said, well, yes, I'm African-American, Black woman, and a nurse practitioner, but now I am not only tasked with my normal job, but I'm also tasked with being on every committee that looks at diversity, and there's no work buyout. I don't get release time for that. It's just added on. So we need to be really aware of what additional responsibilities we are assigning folks when they're already full of things to do. She began practicing gratitude even in challenging situations. And this can be, something that you do through a mindfulness exercise, or also journaling can be very effective. Seeking support from colleagues with shared values, implementing a strong grief practice, and letting go of perfectionism, an idea that she had to fix everyone, because sometimes we can't fix everyone. Focusing more on learning and growing as a provider and being a good patient advocate, and focused on patient care and education and quality of life. Advocating for organizational changes to address clinician burnout. And that's the pay it forward, right? Because some of these things that she was encountering were making work not sustainable for her. So what approaches did she take to manage her symptoms of burnout? She sought help from a mental health professional and learned personal boundaries. So learned to say no to friends and family. And sometimes as a clinician, that's really hard because we fix people all day long. And I think some of that carries over to our home life, right? Well, we're just the fix it. And some of it is because we like fixing things, but some of it is because we're not letting other people learn how to fix their own things. Increasing physical activity can be a great outlet, and dedicating more time to being in nature, because sometimes just a walk in the woods is really, really helpful to reset. I saw one question. Let me click notes. Go ahead.
And Dr. Gorley, I'll read out the questions. We've got a list of them ready for you. Okay.
Okay.
All right. So first question is, what do you first of all, thank you so much for that really in-depth presentation. I think the vignettes and case studies really emphasize the struggles that clinicians are facing in some of their situations, and then also what they could do to really manage their symptoms of burnout and advocate for changes in the workplace. So I will ask you the first question. What do you recommend for providers that have voiced concerns to their directors, but they're not changing and making excuses for the organization? It seems like I'm here to churn patients and leadership, but leadership is not here to support me or my system. So someone who's trying, but it's just not working.
So what I found effective, and it depends on your role, right? I've been a nurse practitioner, so for example, if you happen to be a clinician, yes, you're there to churn out patients. They want you to see as many patients as you can, because there's lots of folks to fix, but many voices. I would suggest looking at your provider group, whether that's in the individual clinic. Many of the federally qualified health centers have multiple clinics, and perhaps, because banding together with other clinicians who are likely feeling a lot of the same stresses that you're feeling might make a bigger impact to your leadership to say like something needs to be changed here. And then also perhaps looking at some evidence about what other similar sites are doing. Maybe so come with also with solutions, and it sounds like you may have done that, but it might have gotten a little poo-pooed. But keep at it. Don't give up, because you know, this is a prevalent issue now. Maybe even invite them to one of the webinars would be my other suggestion. But just keep at it, but also enlist your peers, because sometimes if it looks like it was one provider or one person that's struggling, it might not ring true as though this is an organizational level challenge. But if it's multiple folks saying the same things, then maybe that will sort of raise awareness, and you can have a dialogue about those solutions.
Thank you. So the other question we have is, what recommendations do you have or questions do you advise to address to mitigate or prevent burnout when looking or interviewing for a position? So I guess questions you ask about maybe in the interview process.
Oh, that's a great question. So there's a few strategies I would like. If I would ask for a share day, so you can see it, because a picture's worth 1,000 words. And if you see the operations of the clinic, and they seem to be, going smoothly, that's great. But you can, talk with the providers, and do a lot of observation if you can. So that would be one of my suggestions. But the other thing is, ask very concrete questions. How many patients do I see a day? What other resources are available for patient supports? Some clinics can't afford to have nurses and a social worker and, a substance abuse counselor, et cetera, but they might have a community health worker, and they might have really good relationships with other community resources, so that you as the provider are not the one having to do all of that work with that patient, right? So find out what resources in the community are established and in partnership with that health center, because that will also let you know, like, okay, if they don't have those resources in the community, guess where those resources are? They're coming from you, the provider. And then you have to look at, okay, how am I going to be able to do all of those things, right? So that would sort of tip your hat and to say, this organization might need a few more resources to support me in practice.
Thank you. And we'll just do one more question so we have time for the breakout sessions. What strategies or tools have helped you personally to prevent burnout from your past experiences working in underserved community?
When I was a very new health service corps scholar, they had these sessions. And I went to Texas, and it was like a big conference, right, for health service corps scholars. And this one presenter, she was a midwife. And I told Molly this story when we were talking about this presentation. And she said, it's really easy to get bogged down in how many needs the patients have and how many resources you don't have to help them with, and to get frustrated, right, with that lack. And she said, but what I've been able to do, because she had been providing care for a long time, I look at every patient encounter as nothing short of a miracle, because I know that the patients had to essentially move a mountain to get there. And when I greet the encounter with that space, that sentiment, it's a gratitude. And what I try to do each time I see a patient is say, thank you so much for coming in, because it just sort of reinforces to me that I know you moved a mountain to get here, because you have little ones, you have, no transportation, you have probably very few resources and supports at home. And the fact that you got here is amazing. And that has sort of fed me through my career to, sort of be mindful of, like, I'm very lucky that they were able to come come to see me today. And I might not be able to fix all their problems, but I want to see you back. And if you have that nice space where you're not annoyed and draining yourself before the encounter already starts, it really helps to keep you going. And I still work today, so it's been helpful.
Yeah, thank you for sharing that. I think it's a really great sentiment to end the presentation on. And it was really good hearing about your personal experiences as a scholar, but also just over your decades of working in underserved communities. So thank you so much for sharing all of your expertise. That is all the time we have for Q&A today. So thank you so much again for your excellent presentation, Dr. Gorley, and for the great questions from the attendees. Before we open up the breakout sessions for our affinity groups, we are going to open up the evaluation poll. If you're interested in gaining a better understanding of any of the topics we covered today, we do have some reference slides at the end of the presentation. Welcome back, everybody. Hope you all enjoyed your breakout discussions. Ours was really great, and the physician group, I think some other groups had to combine forces, but hope those went well. And thank you so much to our facilitators today, our